will not replace your hardwood because they are a pelvic floor physiotherapist, not a household floor therapist.
No.
Welcome to Dad Joke Medicine. This is episode 9.
I'm Dr. Paul Dillon. So excited. Last episode of the year.
I'm Dr. Simon Moore, and we are going to cover today, hot off the press. This is the CFP Journal November-December joint combined issue.
That looks amazing. It is literally hot off your press.
Jam-packed with
Printed.
incredible tips and tricks.
Let's start at the beginning.
You got it. What are we going to cover today?
What are we going to cover? Exactly. We're going to do 3 articles. We're going to start off with GSM, then RSV, and then...
LACs.
Yeah, boom. There we are.
You got it. Okay. So let's start with a cover critique here. And this is intended to talk about patients attending appointments from the comfort of their own homes with virtual care.
And what it looks like is it's a physician that's sitting on the same couch who's brought a giant frame and just put it in front of them.
Yeah, exactly. I'm going to come to your home, do a home visit.
Home visit.
But sit behind the plexiglass.
Yeah. Oh, that's probably what it is. All those shares in plexiglass from COVID. I lost all my money.
All right, so let's start about GSM. And hold on, isn't this supposed to be vaginal atrophy?
No, so this has changed.
Vaginitis?
I've seen this in a number of articles over probably the last year or two, almost 3 years.
Yeah, SOGC guidelines have got new name for this as of 2020.
Genitourinary syndrome of menopause. So
Really
this
good.
includes, what is it? It's not just vaginal atrophy. Both vulvovaginal and lower urinary tract symptoms resulting from decreased estrogen levels during menopause. GSM, so much easier to say.
Oh, absolutely. And it also leads into some of the causes and also the effects of this and folks getting increased urinary tract infections. So I love how it broadens your idea of what this is.
And significantly undertreated. So
Oh,
I think
yeah.
they say 77%. Yeah. Genitourinary syndrome of menopause. 77% of women. Often not talked about, underdiagnosed, undertreated. So let's dive into this.
Yeah.
Great article.
Yeah, we got to be screening our patients. It says specifically to be asking our patients age 45 to 69, during routine workflows, during your pap test appointments, ask them about it.
Yeah, and if you don't ask, you're not going to know. So what are we going to do? So say we have a patient who's come in, we think this is what's going on. So what are you going to do? What's your first line?
So first, make your diagnosis and then ask about management with non-pharmacologic treatments, your hygiene, your lubricants, as well as your moisturizers, and very, very different treatments for both of those.
So the first thing that I want to remind people about is you got to moisturize for a month. You think about menses, it's for a month. Sometimes people will try one of these treatments, and there's different ones over the counter, so often not covered. So you've got to think about that when you're counseling your patients, but you got to try it for a month.
Yeah, it comes in gel, it comes in ovules, comes in ointments as well. But yeah, tell them to use it 2 to 3 times a week. And if they come back at 2 or 3 weeks and they say it hasn't worked yet,
make sure you do that whole month.
Moisturize for a month.
And now, next step after that, you want to go on to vaginal estrogen therapy. So this, you go more than a month, you go to your, I guess I would say, a steroid season.
Use your steroids for a season.
So it's got to be,
working.
3 to 4 months is how long it's going to take for these to really kick in.
So I love this article because as somebody who has never suffered from GSM and maybe haven't learned a lot about this in my training, not only does it give the usual list of here are all the options, your rings, your creams, your pills, your soft gels, but it also talks specifically about why you might choose one over the other. It's got the prices in there. This is such a well done article.
Yeah, great article, great table there, especially if you're not that familiar. Maybe you don't have a lot of patients that you've been asking about, but now, trust me, you're going to ask one patient, you're going to ask another, and you're going to start treating, and great benefits.
You got it. So you don't even need great benefits to afford some of these medications. So these estrogen creams, the conjugated equine estrogen, comes from horse.
Do you smell that?
Urine. I smell the cost effectiveness. It's $10.
But what about the smell?
That's
So
right.
the
It's scented.
Equine ones are scented rose. Tried to do a deep dive and figure out why rose was picked. Don't know.
Doesn't really say. So rose scented, but obviously any scented products could be irritating.
Potentially.
So if that is, they come back, they say, don't love it. So then you can just move on to the estrone vaginal cream, which is unscented.
Unscented.
Some folks don't want to be applying things with the most of these need a loading dose. Everything except the ring needs a loading dose. And some people say, look, I don't want to be using a cream daily for 2 weeks and then reduce that. So they say, what could I use once every 90 days?
What is that now?
Well, if you ever are not sure, you could just give me a ring.
Oh, nice. That was good.
It's an old phone reference, like a 90s joke about telephones.
There's people who are listening to this podcast that have no idea what you're talking about now.
Why do telephones ring? Yeah, I took my kids to a museum. I showed them one of those old phones.
Yeah.
That doesn't have buttons. No idea how to use it. No idea. So what about the ring? $30 a month.
Okay.
Pretty convenient. And once every 90 days. And then if that's not something they want to use, the tablets and the soft gels. And once again, the article talks about the difference between those as well. You know, the tablets are going to use an applicator device. Comes in with a single-use applicator, but the soft gels don't have an applicator device.
So when we're talking about these vaginal estrogens, there have been concerns in the past, a black box warning, Health Canada, breast cancer. So these black box warnings are still there, even though SOGC has in clinical practice are using it. But the black box warning advised consumers of risks including coronary artery disease, stroke, venous thromboembolism, breast cancer, endometrial cancer, and all very real concerns. So a great practice tip is to warn your patients that this is an old black box warning and it's safe.
Yeah, and that's the bottom line. It's safe. There's overwhelming safety data, even though the black box warning is still there. Another really good one you mentioned too is about breast cancer. If I've had breast cancer, can I use a topical vaginal estrogen?
So the short answer, yes. So you'll see it.
It says not to in the monograph.
It's often used off-label. It's used across the country. I've seen it as well.
Amazing. Now, what about GSM using those newer medications? You know, the ospemifene and the prasterone, not adequately studied in folks with breast cancer.
Sure,
So,
but for other people, another option. So a tablet, if they're really not into using the creams, another option. So those are the SERMs, selective estrogen receptor modulators.
Now, we spent a long time talking about drugs and creams. What are the non-pharmacologic options? Hygiene. Avoid those irritants, those rose-scented creams that you prescribed.
Avoiding toilet paper made of recycled paper. That's an interesting one.
Great for the environment.
Climate friendly.
Bad for your vulva.
Yeah.
And regular sexual touch can help by increasing vaginal blood flow and secretions.
Okay.
Definitely not a dad joke medicine episode I'm going
No.
to play for my kids.
No. Yeah. Not safe for kids.
Yeah. Whether with a partner alone or with or without a device.
Okay. There you go. Boom. Physical changes associated. You can have narrowing. You can use vaginal dilators as well. And dyspareunia from dryness can also be an issue.
What is an allied health referral that is absolutely in your armamentarium for folks with, post-delivery vaginal symptoms, vaginal dryness, genitourinary syndrome, or menopause?
The answer to this one.
Well, since nobody
Pelvic.
here seems to know.
Come on, ask me. Pelvic floor physiotherapy.
You got it. Just be sure you remind your patients that they are quite invasive in their exams and their assessments. It's not like I can do some arm stretches. Not that kind of physiotherapist. And they will not replace your hardwood because they are a pelvic floor physiotherapist, not a household floor therapist.
No. Oh my God.
If it hurts your head, that means it was a great dad joke.
That's brutal.
I saw the pain there.
Okay, and the one thing we haven't mentioned that's in here is UTIs.
Oh yeah.
So reduction in UTIs. If you've got a patient who's had 2 UTIs in 6 months, 3 in a year, you've got to be asking these questions. Maybe you can avoid UTIs. Yeah.
Phenomenal. Let's move on to something that is relevant to our newborns. And in fact, even before they're born, our pregnant patients might want to take these medicines to try and prevent RSV.
RSV. So this was new to me. I've heard this. There's been some advertising. I've seen the new Health Canada updates on this. But essentially 3 things. 2 monoclonal antibodies, the injections, and these are for kids, little kids. But which little kids? Is it every little kid? Is it every province? What are some kids you're more concerned about where you'd be thinking about the monoclonal antibody?
Well, it depends who you ask.
Okay.
Because if you ask Health Canada, they actually say we should be giving a monoclonal antibody to pretty much every kid who's newborn about to enter their first RSV season.
RSV season.
So why don't we do that? Why don't we give it to every single newborn?
probably how much it costs.
Yeah.
And it's up to the provinces, essentially, to implement. I know Quebec, Ontario, 2024, 2025, it'll probably be 25, 26, where they're implementing programs. So it's not everywhere, but be prepared to answer questions from your pregnant patients about this. And so that's the monoclonal antibodies. That's for the kids.
That's your pavlizumab and your other one. What's the other one?
Nivolumab, is that
It's
right?
got RSV in the name.
In the name. There you go. That's a great way to remember it.
Yeah, nivolumab is the one that is recommended by Health Canada for every kid, but it's going to be pricey. It's going to be $952 a dose.
And we should probably talk a little bit about those kids. So immunocompromised, pre-existing cardiorespiratory disease, they're premature, and residents in indigenous, remote, or northern communities. So that's a great list. Could show up on an exam.
Now, what if you're lazy and you don't want to just give the monoclonal antibodies? You say, I want the pregnant parent, I want the pregnant mom or the pregnant person to make the antibodies for me.
Put them to work.
You got it. Give it, and it's actually a third of the price.
Oh, interesting.
Yeah. So instead of getting a lab to make the monoclonal antibodies, why do you get the
mom to do it? Maternal labor.
Get them into labor before they go into labor. And
I hope that vaccine doesn't do that.
Yeah, exactly.
So 32 to 36 weeks.
Yeah, you're going to give them a dose of a vaccine called Abrivso, and not to be confused with Arexvy. Arexvy, that's the vaccine you've heard of in the ads that is really useful for folks 60 and older.
And there's been cases where they've mixed these up. I think there's actually a warning. Yeah. Okay. They've given the pregnant patients the over 61.
So the Abrivso is the one that you want to give to the pregnant folks. It's the pre-F version of the RSV, and that only is going to cost you about $230 because they're making the antibodies for you.
I feel just looking at all these names, have we reached peak difficulty in medical pharmacological treatments?
We're running out of consonants. I got to say, though, the monoclonal antibodies have been amazing for my Scrabble game. I think that nirsevimab is like an 8,000 point word.
You just make it up if you're playing with non-medical people.
You just like dump the box.
As long as you get like an MAB, you're done. You're going to win. MAB. The second, there's 3 letters. Boom.
So it does help. It does reduce the amount of ICU admissions. It does reduce the amount of RSV infections. Very interestingly, the old version, the pavlizumab, you have to give it once a month for 4 months, $1,200 a dose.
Wow.
The new one is the longer acting one. So that's the nirsevimab, and it works for up to, 8 months. They've got data for 150 days, and they expect 8 months.
Okay.
And the vaccine, of course, you give it to the parent before they give birth, and then they get 6 months of antibody protection for the kids.
So you're essentially buying time for these kids at higher risk for complications if they get RSV, and hopefully they get past 2 years. And then I think that's where the indication essentially stops, because you've gone through 2 RSV seasons, you've hopefully grown up, and you're able to handle it when you do get it.
Yeah. I mean, if you've seen RSV in a newborn, it's just clinical support like fluids and oxygen. It's really tough to do much more than that. And finally, we can now say, yeah, you could have prevented this. Really useless thing to say.
Now, they don't actually go into it. If you have a second pregnancy, do you get it again?
RSV again?
Do you get the vaccine again?
With
you give
each
it to the mom with each pregnancy? It is? Okay.
I believe so. So we'll look that up.
Okay.
Thanks
Just
for your
threw
good
that
question.
out there.
I'll ask
higher
you
levels.
a tough question for the next one. I bet you don't know anything about simple excision and wounds, do you, as an ER physician?
All the time. I love these. It breaks up the day. You can save some time if you're using glue, but this is actually a pretty decent article.
Yeah, I would say that they really sliced into the evidence nicely on this.
Just cut it down. Yeah. It's a cut above this article.
It's a sticky topic.
Oof.
Glue for incisions. So what do we use? Do we use the steri strips? Do we use the glue? Do we use the sutures?
Or a combination, all of the above.
What does the evidence say?
So I think context is important. Simple lacerations, clean with tap water, and repair with clean, non-sterile gloves. So this is something I've seen in the past 10 years. Used to use all that sterile water, very expensive water, and now it's normal tap water within Canada. Spray, 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 wash, wash, wash. Copious irrigation, and just use normal gloves. You don't have to use sterile gloves.
Oh yeah, I've seen patients using peroxide, chlorhexidine on these wounds, and one of my favorite tricks for lacerations, you numb up the area, and then once it's numb, you say just put your arm under running water, clean out that wound, wash out all that bacteria while I go do some charting. So you can look up another patient.
Oh, interesting.
Nice clean wound. Learned that from an EM podcast about 15 years ago. So,
wow.
So what does the evidence say? Which one's going to dehiss? I mean, it makes sense. If you stitch something shut, it's going to stick together a lot better than if you glue it shut. But we actually now have the rate.
Yeah, but it's not a huge number. What do they say here, Simon?
It's 4.5% with glue
versus
are going to dehiss.
1.3, yeah. So like 3%, 17 RCTs with an N of 1,200. So they're pretty small RCTs.
Mm-hmm. Differences with infection doesn't matter. Same amounts of infection with glue, with steri strips, with tape. They compared skin glue versus tape, and then they specifically compared suturing with skin glue. No difference in infections in those studies. And do you even need to close a punch biopsy?
So this is interesting. So 4 and 8 millimeters. My big takeaway from here is cosmesis, patient satisfaction. At the end of the day, it's almost all the same.
Yeah, a 4 millimeter punch biopsy, they say, small study, 77 folks with RCT. But if you just do your punch biopsy and say, see you later, here's a Band-Aid, it's going to be just fine. It's
No difference.
Close.
Yeah.
9 months later, no difference in clinician-rated cosmesis.
Yeah. But now the caveat there, half the patients did prefer to have it closed.
Mm-hmm. Makes sense. You don't really want to leave your doctor's office with a gaping
Holes
wound.
all over. 4 millimeter holes all over you.
It's the Swiss cheese model of patient safety. Well, have we reached closure on this topic on skin closure?
Oh, nice. Yeah.
I think we've reached closure on Dad Joke Medicine for
Dad Joke
2024.
Medicine. What a great year.
Wrapped up CFP Distilled for 2024. That is the CFP Journal topics, all distilled down for you. Really useful, I hope. Signing off.
Signing off. Hope you have a great holiday season, and we'll see you next year.
You got it. I'm Dr. Simon Moore.
Dr. Paul Dillon.
Till next time.